Used by Dr. S K Poddar, sir.
Thank you. Thank you, Dr. Chauhan. I think whatever you said for Dr. Viveka was true. For me, it was exaggeration. But anyway, thank you. Happy New Year to all. Dr. Viveka, as he said, Dr. Chauhan said, he is the best friend of Asian Forum of India. And to most of us, personally also, he is the best friend. He is one of the best cardiologists, not only in Delhi, in India. One of the most accessible person in Delhi. As cardiologist, we can access to him in the midnight also. He always responds. And we all know, he is the principal director of Cath Lab in Max Hospital, Saket. No needs of introduction. So I welcome Dr. Viveka Kumar. It is, as he said, it's Amrit Mahotsav. So not Azadi ka, it's Bandhan ka Amrit Mahotsav for Dr. Viveka with Asian Forum of India. I request Dr. Viveka to start. One of the best cardiologists in India, not in Delhi, Dr. Viveka. And the topic is latest trends in percutaneous interventions in cardiology. And please don't make noise. It's a request because it's ultimate respect to the speaker. If you don't make noise, everything is being served at your table.
Well, so first of all, Happy New Year to all of you. Happy 2024, and special thanks to Physician Forum of India and Dr. Chauhan, Dr. Poddar for chairing this session. I think this is a bunch of young guys who come every Wednesday to enjoy their evening. So this could be the inspiration for many young people around the world, not only in India. And Dr. Almas, who is putting all these events on YouTube, I guess, and so that would be, people will get inspiration. So today, just we have to, in association with Healthy Heart Society, which has been supported by Boston Scientific, Medtronic, and host of other well-wishers. Because all, what we do, you could see that the interventional cardiology is progressing at a very rapid pace, and here the motto is to decrease the patient suffering, do the procedures with minimally invasive procedure so that they can have a daycare procedure, and of course the complex diseases could be managed in a very, very, simple way so that they can have no scar, they can walk off in a day, and the suffering is minimum and the longevity of the patient increases. So if you see the cutting edge of intervention in today's world, the tenet is that anything which a cardiac surgeon can do, we can do without opening the chest, and that is the basic thing. And if you look at the evolution, we have looked at not only changing the aortic valve, which is a tablet procedure, we close the atrial appendage, now repairing the mitral valve by mitral clip, where the surgical skills used to take years to train, and still the perfection was not there. And of course, without any scar, without any lead, you can change the rhythm of the heart by a leadless pacemaker. So the difference in open heart surgery and the minimally invasive procedure is that this is on the left hand side. You could see that the surgical colleague had to open the chest, open the aorta, and reach to the aortic valve to change it. But here, through the right groin, right femoral vein, or left femoral vein for that matter, we could go in and change the valve completely. So in the box we have absorbable stent. Now it is second generation absorbable stent which is making come back. Then we can change the open the narrowed valve which is called balloon valvotomy. We can change the leakage of the valve can be repaired by mitral clip. We can now replace the valve by mitral valve replacement. TAVI procedure has obviously become as common and frequent like an angioplasty. The people who cannot tolerate oral anticoagulants and have got atrial fibrillation, to decrease the risk of stroke, we can close the appendage by Watchman device. Now we have got a new Watchman Flex from Boston Scientific, which is much more advanced and much more secure. Pulmonary valve implantation can be done. So there are a lot of patients who have had congenital heart surgery like tetralogy of Fallot and all, and then eventually they developed leakage in the pulmonary valve, and there we can change the valve percutaneously by Melody valve. Leadless pacemaker, which is a micra. We can also, sudden cardiac arrest can be treated by subcutaneous ICD, where nothing goes inside the body of the patient, so everything is between skin and muscle, which is subcutaneous ICD. And if the patient fails all the supports, then we have artificial heart or left ventricular assist device. And you'll be surprised to know that all these devices can be managed when the patient is at home, can be monitored, which is called home monitoring for these. So this is an absorbable scaffold. So it went into this recognition after a lot of there was slightly higher complication rates compared to the current generation stents, and then it had been withdrawn. But now the second generation absorbable scaffold can come. So now in India it is available, and all of us know, and I think many of you would remember this slide, that normally this is the furring of the artery. So the cholesterol blockage develops within the artery, and once the block ruptures, these flowing blood, they get clotted and acute heart attack happens. So we pass the wire across the blockage, we balloon it, and this is the stent. It has a drug over it. It keeps on releasing for 3 months, and the risk of restenosis is taken care of. So we very infrequently now hear about the restenosis, and that's the reason why the number of interventions have gone almost 3 times more than the open heart surgery, simply because the restenosis is something which is very, very uncommon now. And thrombosis is also very uncommon. A lot of patients who would have a mitral valve stenosis, we do a balloon mitral valvotomy, which is again a day-care procedure where the narrow valve, we do a transeptal puncture. So what we do is that we go through the right femoral vein and do a transeptal puncture, and then this is the place where we do a transeptal puncture. This is the stenosed valve. So we take the balloon across this and just blow this balloon up, and then these commissure, they open up, so the patient would have open valve. Unfortunately for patient and us, this remains open for a very long time. So there are a lot of other procedures like closed mitral valvotomy and all now it doesn't exist because surgeons have also forgotten to do this procedure. So balloon valvotomy is such a big procedure. Now, if you see the leakage in the valve, where the prolapse in mitral valve space is there, so obviously when you put a new valve, the patient has to be on oral anticoagulants, and the risk of blood thinners, you would know the risk of bleeding. A couple of days back, I had a patient where I had put a stent, almost 8 years back, and he had a fall while walking in the park. Another doctor's brother-in-law, and he developed subdural hematoma just on plain aspirin. So you can imagine that we should try and avoid anticoagulation as much as possible. So obviously we need to give the treatment which is not requiring strong anticoagulants in these patients. So if the patient has got mitral regurgitation, we can clip that, and we have done, now we are doing one of the few centers in the country which we are doing it on a regular basis. So mitral clip is something, though it's costly, but it's very cost effective, and especially in those patients who have got very poor ejection fraction, their high surgical risk, their changing the valve will not work. So suppose this is a redundant part, we could put the clip and the leakage goes off. So this is very, very important, that this is something which is done with 3D echocardiogram, transesophageal echocardiography, and this is the mitral clip, how it will look on X-ray. So what we do is that the mitral valve becomes a double orifice structure. So there are a lot of data. This is one of our patients where we have done, and you can see the echocardiography shows that there is hardly any leakage. We can, valve in valve is something which is very, very important procedure. It can be done in mitral space. So, remember a lot of patients who have rheumatic heart disease, young females who had, not completed their family. So in those cases, surgeons would put a tissue valve, but our tissue valve has got a life of 10, 12, 15 years at the most. So they re-stenoze, and in this case, what we do is, if we re-stenoze it, whether it is mitral space or aortic space, we could, put a valve in valve, which is again a TAVR procedure, and it can be. So this is a patient who has had a, you can see this is a mother of a, cardiac surgeon in US, and she was 84 years, and here she had a, this valve lasted for almost 18 years. At the age of 85, she has a degenerated mitral prosthesis, degeneration, severe stenosis. So we did a transseptal puncture, we did a, a flossing of this structure, and then dilated the intrathecal septum, crossed to mitral valve, and we implanted a new valve. You can see that once you implant, so this is like a, again a balloon expandable valve. So this valve is going in, and so you have to place, this is a old valve, and within that the new valve is going. So that is why this procedure is called valve in valve. And this is in the mitral space, because redo open heart surgery will be very risky. So once that is there, we inflate and the valve implantation is complete, and you can see that it starts functioning immediately. And this 84-year-old lady got, went home next day. So that is the beauty of this procedure. So in de novo patients where there is no, previous mitral valve, that's a difficult proposition, because unlike the aortic valve, mitral and tricuspid valves are more complex, but still we have 10-9 valve and other few valves which are, not yet FDA approved, but they are getting approval for, implantation. In aortic space, now we have come to, a space where on a regular basis, all patients who need a tissue valve can get a TAVR valve. A couple of years back, we did one nephrologist who is from Finland, Indian origin, and he said that 70 years of age, and he said that if I get an open heart surgery, my practice will be gone, because he is running, have got many dialysis units in Delhi, in Russia, in Finland also, and he opted for this despite saying that you are a low risk patient and you can get an open heart surgery, but he was just not willing. So you need to have a suitable patient, heart team, and hybrid lab. And we started, so we can do from right femoral. In his case, we did from right femoral artery. We can go from left femoral if there is some issues here. We can go from left subclavian. In a couple of cases, we have gone, transaortic as well. So basically, if you classify all these valves, there are two types of valve. One is self-expanding, and other is the balloon expandable, and most of the time you can choose either of the two. The one promising valve which has come here now available from Boston Scientific is what we call accurate Neo2 valve, which has got the advantage that frames are very wide, so it's an advantage. You can do accurate positioning, and also the coronary access is considered to be slightly better. So these are the benefits of this valve, and so. When you look at one of the issues with the Evolute older frame was that access of the coronaries was considered to be difficult, not in all cases, but sometimes. So in those cases, we used to choose the balloon expandable, but there are certain situations like heavy calcium and all where we don't want balloon expandable because the aortic rupture and all would be higher. So in these situations, accurate Neo was considered to be one of the better valves. But this is one patient who was very, very sick. Their children were in the UK, and they were, when I was in UK long back, they were, my next door neighbor, Indian patients, and this was his mother. So you could see that, the structurally things were okay, but she was very, very bad substrate, and there was heavy calcium. In this case, we did a, analysis. So all these patients need a CT analysis to size the valve and to predict good outcome, and then this is a patient where you can see the large and the black things, the large calcium. So we did a first cross the valve, and then we did a balloon dilatation. So pre-dilatation is mandatory for this. So we did a 20 O balloon dilatation, and after that this is the implantation. So the beauty of this valve is that the proximal part is first deployed, so that the migration is minimized, and then the distal part will get deployed, and the post-deployment results. So you can see this is the part which is first deployed, and the valve, the part which is across the valve, it gets deployed last. So after this, you can see this is a fully deployed valve, and the outcome. So this is more than a couple of years, and the patient is doing absolutely fine. So if you look at the mortality data, it has significantly come down. So whether you look at the, this is the delivery system of Medtronic Go valve, and it has evolved now, I think in India on the second, so I think a day before FX, which is the latest generation self-expanding valve which was launched in, and so the basic principle is same, but the FX, the advantage is that it has got a single spine, so the predictability and efficacy is much better. So if you look at the patients who would need, either valve-in-valve, so valve-in-valve I would consider that the TAVI is a boom, because the high surgical risk of redo surgery is negated. Aortic regurgitation is not yet a fully approved thing, but we have done few cases. Only one valve, which is Jena valve, has been approved for pure aortic regurgitation. But we have done in many cases where some mixed aortic stenosis and aortic regurgitation results were there. There are a lot of patients who have atrial fibrillation and has they do not tolerate NOACs or oral anticoagulant. So there, to decrease the risk of stroke, we do a Watchman device, closure of the aortic left atrial appendage. In fact, I've done it in my own mother-in-law's case, who was having hypotoxicosis, atrial fibrillation, 6 sinus syndromes. I put a leadless pacemaker and this Watchman device. Now we have got a new Watchman FX device, which is much more safer and predictable. But there are a lot of other companies like Amulet and all from the Plaster and all. But obviously, this is something which is very, very important, device in current stage. The tricuspid anatomy is something where a lot of patients who have got open heart surgeries and the tricuspid regurgitation is left, they are the ones where the leakage in the valve is caused ascites, cirrhosis, peripheral edema, and you put tons of diuretics, but still the fluid overload is there. So this is called bicable valve, where we put one in the superior vena cava, one in the inferior vena cava. So the tricuspid regurgitation is negated, and the systemic plethora this goes down, and these patients do really well. Now we have got dedicated tricuspid valve where in appropriate anatomy we can do percutaneously, and that is also again. So for all these procedures we need to do a CT analysis to find out the suitability and size of the valve, and then after the measurements. So 90% of the procedure is done by planning on CT, so whether it is TAVI or MICRA, or if we do the tricuspid valve. Then I was saying that the most wonderful therapy is the leadless pacemaker. Now we have got what we call VTD or dual chamber also, MICRA AV, where it's a 2 cc capsule which could, people feel that how could it have such a long battery life, but it has almost 13 years battery life. It is Bluetooth compatible and also MRI compatible, so you can get an MRI done. And for that same reason, because there is no lead, no scar, so the risk of complications are 52% lesser in these cases. So this is the magnified view of the same people lines, which we take help of getting entangled into the myocardium. Usually we keep it on the septal side of the right ventricle, and safety is unparalleled as far as this device is concerned. This is another one patient where how it would look an X-ray. So once the device is in the sheath, and then after deployment, these are the times you could see. So these are entangled into the myocardium of the septum, right ventricle. Subcutaneous ICD, again, it's a wonderful device for prevention of sudden cardiac arrest. So you can see that everything is between the skin and the muscle of the chest. Nothing goes, so it doesn't destroy the vein of the patient, so that is why it is more attractive for prevention of sudden cardiac arrest. And there's a lot of data that suggests that it's a very, very safe device and very effective. And all these devices can be monitored at home, so home monitoring of all these devices is available. So if the patient is anywhere in the world, he can have a home monitoring. But if everything fails and the patient lives longer and you don't get heart for the heart transplant, then these patients can get artificial heart and what we call left ventricular assist device. Now, we have longest follow-up of 6 to 7 years of the patients who are on LVAD, and they do really well. There are a lot of patients who LVAD is as a brisk therapy, but for acute support we have Bella devices, so based on that we can, or tandem heart, which is all available with us. But obviously the left ventricular can also, LVAD can be used as a brisk transplant also. But definitely we have discussed in other CMEs that the power of newer heart failure treatments have also decreased the need for these device therapy in heart failure. But nonetheless, there are a lot of patients who would need it at the end of the day. So this is an LVAD patient who could do everything except for swimming in a swimming pool, and he can lead a normal life. So to conclude, I would say that the interventional cardiology and the cutting edge advances has really gone a long way. The absorptional stent, the Darby procedure, mitral clip, Watchman devices, leadless pacemaker, and everything has really made huge impact on the longevity, quality of life, and the survival of our patients. And I think the end of the day, all the patients are going to benefit from this, and we can not only conquer it completely, but we can make our patients' life more comfortable and longevity can be increased. And this is where we do all these things at Max Success. So thank you very much for your kind attention. So I had a chat with Dr. Chauhan that on every opening, CME, we will have the advancements because whatever has happened in the last 1 year, we can have one more. Thank you.
So thank you, Dr. Viveka sir, for telling everything what is latest in intervention cardiology, whether it is valvular lesions or arrhythmia cases or heart failure. So everything what is latest in cardiology intervention. So my first question is, when we apply treatment for mitral regurgitation, how do you decide that this is in the right position? And if it is not in right position, can you detach it and reapply it?
Yeah, so I think that's a million-dollar question, because unless you are sure, you cannot release it. So it has a mechanism where you can, redeploy it, you can remove from the deployment and what we call recapturing, and then after that you can redeploy. So the purpose of this detachable device is that you first do a clip, then because it is again a transesophageal echo guided and fluoroscopy guided procedure. So we first check whether the MR has gone completely or not, whether both the leaflets have got entangled in that, and once we are 100% sure, then we release it. Once you have released, then obviously you cannot retrieve back. So you need to be 200. So number one is that we get guided by transesophageal echo, the fluoroscopy, and the pressure gradient. So these are three things by which we do. And if we are not happy with that, we can remove the clip and apply, recapturing and then apply it again.
My only question, next question, the final question is, LVAD device can be used as a bridge therapy for patients who are waiting for transplant. But when patient does not get heart for, or he is not ready for heart transplantation, can it be prolonged for 5 years, 10 years?
Yeah, so that's what I said, that it can be used now as a destination therapy also. So we, in our follow-up also, we have around 6 to 7 years follow-up of the patient. One patient we had a 6 years follow-up who died during COVID because he was cerebral bleed. But definitely, there are a lot of patients where the patients have said that, so there are two things. One is that the patient was in severe heart failure and the heart failure is improved. and you can remove the LVAD also. But if a heart failure does not improve, and the patient gets, especially in younger patients, they get a new heart, and the heart transplant can be done. Because for LVAD, you need total anticoagulation therapy, and I said that as the age advances, this completing and all can go. But answering your question, yes, we can use LVAD as a destination therapy also rather than bridge alone.
It's a wonderful talk, as always. Dr. Tulsi sir, Dr. M.L. Kabra sir, Dr. Viveka sir has said that he will only take dinner if we can finish the question answer session in next 20 minutes. After that, no, just listen to me. Dr. Alpna has told him that after that you have to have dinner at home. So you decide, sir, we need to finish this off in 20 minutes. Then he has promised to have a drink with us and also the dinner.
Once you finish.
I'll finish in next 2 minutes. Sir. Yeah. You ask first.
So this is a story which you must listen very. I'll be in short and very important, and there are questions in it. One of my very close relatives had an anginal problem, and his CT calcium score was more than 400. He was referred to National Heart, and angiography and echo, everything was done, and he was advised surgery. And there was multiple stenosis, calcified coronaries, and a severe aortic valve stenosis. So he was advised surgery. They came to me. I talked to doctor immediately. I talked to Dr. Viveka. I said, send me immediately. So they went to him, and they told me that he just saw the videos forward, backward many times, and advised them CT angiography. And then next day, his entire team was there, and they said that we will do all the three things: the rotablation for the calcification, 4 stents something, as well as the TAVI in the same sitting. So, and he quoted a package of about 30 lakhs. Now, they were a very influential family of Delhi, political, and they went to some Padam Shri interventional cardiologist, and he also said surgery is the only way out. And the surgeon at NHI also said surgery is the only way out. And they were worried. 58-year-old diabetic, वो बोले chest भी कटेगा, heart भी कटेगा. So my younger brother, Dr. Jeevak, is a neuroradiologist at Rochester, New York. They sent all these things to him. He consulted the cardiology team. They said that normally we would do surgery, but if there is a skilled interventional cardiologist in Delhi, then you please go to him. So they came to me, told me everything. I talked to my brother, Dr. Jeevak, and he said. So then they went to Max, and they also consulted a colleague of Dr. Viveka, and he suggested that yes, you can go, and he quoted 39 lakhs for the package. Dr. Viveka had quoted about 30 lakhs. Wow. So ultimately they got it operated from Dr. Viveka, and he's doing very well, fine. And I have 4 questions in this, sir. Number one, they always say a 55-year-old diabetic, surgery, in this kind of a setting where there is calcified coronary, there are 4 or 5 stents you have to put, then you have to do TAVI and everything, they will say surgery. And an intervention cardiologist, Padam Shri, also says surgery. What did you see in that you thought that you could go for intervention? And the other thing, as I asked you, the same setup. You are quoting 30 lakhs, other person is quoting 39 lakhs. I mean, this was a news to me. And third question is that when will, everybody was saying surgery, you did intervention. When will you say that surgery and no intervention in such a setup?
Before Dr. Viveka replied, we must give a big hand because of the wonderful work he did in your case. It was advised by your brother's friend in New York also. So thank you, Dr. Viveka.
तो सर ने फीस छोड़ दी ना, तो फीस होगी
Dr. Viveka.
Yes, I think that is answering the last question because he has come through Physician Forum of India. So he got a discount. Answering the, so obviously there is no one solution to a problem. So the solution can be, so if your solution in includes the buy-in from the person who is suffering, then your success is higher. So I read the mind of the person, and so obviously, when you look at the short-term and long-term longevity of this thing. So as a human being, so as a doctor, I always say that, the first day in my medical school, I was a very reluctant, medical person. I never wanted to be a doctor, but I went to medical school, and the first day I was told that, remember always that you are a human being, a doctor, but you should never play a god. So you should not say that, if you do this, you will not live, and also you need to just, at best, you can just quote these statistics. So in this case, we gave the final opinion only after looking everything. So technically it was feasible. So quite a few patients, so I learned from one of the patients, where everybody said that if you are a diabetic, you have multivessel disease, so if you get the bypass and open heart surgery, it will last for 14-15 years. If you get a stent done, it will last for 8 to 10 years. So I told this patient that, the longevity is an issue, but if you are open to have repeated intervention, we can do an angioplasty and you can. So he said, sir, long term ke liye apna short term kyun kharab kare? Means that the open heart surgery in every, best part of the world has, at least 2 to 3% mortality, whereas here the mortality was almost, 1 in 100,000. So for that reason we did that, and then when you carefully evaluate you need to see that what are the critical problems and you treat that. And most of the patients would, so one of our technicians used to say that cardiac problem is like a fire. Wherever the fire is, you douse that, patient will be okay. Then next fire, you wait for next fire, if it happens, you douse that. So similarly, the coronary artery, so as your advances, the new blockages, so it is not a curable disease, it is a preventable, so this is a palliative therapy. And these are like if you have a car, if you don't change it, you keep on repairing. So it will need a frequent repair. So that is how, so obviously the safety of the patient, the safety of the procedure, and as he rightly said that the skilled interventional cardiologist, so you need to have a faith in yourself. And sometimes patient has more faith in myself than I have in myself.
Since Dr. Sushruth mentioned this patient, I would like to present Dr. Jitendra Saxena, our darling from the group.
I love him.
We love him.
Everybody.
And not in the least.
No, not in that manner, but another.
Not in the least because he's a Modi fan. I am also a Modi fan.
I am a Modi fan.
Yeah. But he's a hardcore Modi fan. I am a softcore Modi fan. Since Dr. Sushruth related that event, 4 days ago I got a call from him, and his brother's mother-in-law, she was getting chest pain, was admitted in a very eminent hospital in Delhi, and the doctor, the attending cardiologist, said it is a triple vessel disease and including a left main, and we will have to do a bypass. I just asked him what is the age. He said, sir, 80 plus. I said, यार 80 साल के प्लस में चेस्ट वेस्ट क्यों कटवा रहा है? एक काम कर, डॉक्टर विवेका के पास ले जा, एंजियोग्राफी करवा ले, ट्रिपल वेसल डिजीज है, 3 स्टेंट डलवा ले, 14-15 साल निकल जाएंगे, 100 साल चाहिए ना. I would ask him, I would request Jitendra to relate his
since brother is here, whose mother-in-law happens to be the patient, and he will in fact give the details. But it's a similar case, just like Dr. Sushruth said, NHI admitted NHI, triple vessel disease, advice surgery, and then what happened, he will know. I'm really grateful to Dr. Viveka. He did not lose a minute in seeing come over. Doing the angiography, he explained very well how the thing was. There was a big calcium load and 4 blocks. And he used that new technique of intravascular lithotripsy to take away the calcium and then put in the stents. So, one, he has the latest technology. 2, he is confident he can do it. So, he put in 3 stents and angioplasty on one of the blocks. And all things were done yesterday. Today evening, my mother is going to come home. So,
Dr. Saxena Bhai Sahab is a DM in onco. He is an eminent oncologist. Transplant, I'm so sorry. He is an MCH in urology and he is a renal transplant surgeon. I keep confusing between him and BK Success.
आपको अपने बीवी का आशीर्वाद मिलेगा।
I'm not going to ask any more questions to Dr. Viveka. I would give it to Dr. Tulsi and Dr. ML Poddar, sir.
Thank you, Dr. Chauhan. So, some wonderful insights on structural heart disease, especially the microchip. So, what did you say? Okay, so Dr. Viveka, so interventional cardiology has made a quantum leap in the advent of transcatheter valve repair or therapies. TAVR started it all. Now we have mitral valve repair or replacement, groundbreaking options. Of late is the tricuspid regurgitation, once a neglected valvular disease, is now being treated with repair or replacement. They have been historically difficult to treat medically or surgically. Now, there is irrefutable evidence that this can be treated, the repair or the replacement for the tricuspid valvular disease. Talk us through that, sir.
Yeah, so I think you have summed it up correct in that now all the pore space of the valve, whether it is aortic, mitral, tricuspid, and even mitral, so all these can be addressed, transcutaneously with very good outcome. But only downside is that the cost. So they are coming at present at a very high cost. So when we started in 2015, the TAVR program, the cost was around 30-35 lakhs because we had to import things and then get things done. But now, things are being done even with the American valves with the latest Evolute platform. You can do it in less than 25 lakhs, even with the if you see the accurate Neo, the same range. So most of the American FDA approved valves are coming in that way. The Indian valves have made the competition more stiff. We can do it in 10 to 12 lakh rupees, but definitely it has changed the landscape. And the impact was so huge that the government of India has, the health department has released, note a couple of weeks back that is being now recognized in central government health services and all the government panels as well. So you can imagine that how common it is.
Right. So my last two questions would be regarding the revascularization strategies for STEMI with multivascular disease, MVD, what would be that? Multi-vessel disease. So, treat the culprit vessels only or non-culprit vessels as well with complete vascularization, MACE 9% versus 27%, 23% was once culprit vessels were treated. So this, and what about in the cardiogenic shock? If you have a cardiogenic shock and you need to treat culprit vessels as well as non-culprit vessels, I'm talking about the shock trial. Talk us through the shock trial, sir.
Yes, I think you have raised a very important point because, for ages we have been thinking that just do the culprit vessel and come off. But now the data is quite compelling that, if you don't treat the significant, so remember the word significant disease. Significant disease, so if the patient is in shock, so you are giving the other neurons in the heart to raise their head. So if you treat everything in one go, then probably the things are better. But one catch is that if you are treating all the multivessel lesions in acute MI, then you need to use the contemporary antiplatelet because those which sets in action is within 1 hour, like ticagrelor or prasugrel. Ticagrelor is obviously much more safer. So now the data is clearly loud and clear that in multivessel disease, especially those who are in shock subarm, they do much better if you treat all the significant lesions in one go rather than leaving another. So there are many times that the patient, LED acute MI or the antival MI came, because remember these are the patients living MI. They are under immense stress. So one plaque rupture, you fix that, and while he is in ICU, the next flap ruptures and then the patient will have. So might as well treat all the lesions which are significant. So you can leave only the smaller branch arteries like diagonals and ones, but major arteries should be treated, and that has shown, as you quoted the data, that the 9% MACE versus 23%. So that's a huge difference. So now we go that all the significant lesions should be treated.
Great, sir. So, talking about the pulsed atrial fibrillation trial, pulsed field ablation in persistent atrial fibrillation therapy, damage to the phrenic nerve, to the pulmonary veins, and esophagus damage was seen in the thermal, ablation, not with the pulsed atrial fibrillation trial. So, is this now the new modality of choice for atrial fibrillation, the pulsed AF?
Yeah, so I think now in fact we have gone a step further. Now we use cryoablation, which is a cold ablation, where the temperature goes to minus 40 degrees. So cryoablation, if you have ever, though obviously it is compared to normal cost of 2.5 lakh rupees for pulse therapy. The cryoablation costs around 8 lakh rupees, but the complications rate, perforations and all is significantly lesser. So I think the cryo pulse therapy would be the best treatment in this situation.
Dr. Viveka, my last question will be regarding VT ablation. First line therapy, even before you could give an ICD to the patient, the VT ablation, sir.
Yeah, so VT ablation should be, if you look at the accuracy and success rate, it is much higher with the 3D mapping. So then you can find the substrate, so activation mapping of these VT, and then ablating that. So obviously, even if you have given the ICD therapy, the patient will have miserable life because of repeated shock. So even if you have given an ICD, on top of that, you need to ablate to decrease the arrhythmia burden and the shock burden. So obviously, with the accuracy, with the 3D mapping, we have been, even in that, there is a what we call blanket ablation, where the patient would have radiation, and it has been seen to work in these group of patients. So if you are not an electrophysiologist, you can do a blanket radiation therapy, and they tend to have decreased VT storm. So now in younger patients, those who get VT storm, we have got another therapy which called it sympathetic and so there also you can decrease the burden of ventricular tachycardia. But definitely the horses for the courses, so whatever the problem is, you individualize the treatment rather than a blanket.
My last question regarding your friend, the president of the American Heart Association, Dr. Joseph Wee, talked about gene therapy or stem cell therapy in inherited cardiomyopathies, and he said that propylovastatin and pleiotropic stem cells probably is the modality of choice here on the inherited cardiomyopathy, sir. Just a word on that, your friend, Dr. Joseph Wee, the president of the American Medical Association.
Yes, I think that is something which would be the future. So I think the way AI and all these things are going, probably the future of medicine will be far different than what we are seeing. So you rightly said that the gene therapy and the focused gene therapy would be the way forward.
Thank you, sir.
Dr. Kara, just 1 minute. Is there any role of RFA, radio frequency ablation, as we use in varicose veins, peripheral vessels, in coronary vessels? Any trial of RFA?
Yeah, so radio frequency ablation is, we have gone a step further. We do a laser for the total. So chronic total occlusion is the only situation where the RFA or the laser therapy is given to cross the laser, but it's not the first choice.
Yes, sir. I am the last Daba of this train. I won't take more time to delay your dinner here and at home. Sir, firstly, I welcome you as our only speaker, the batsman, starting batsman. Kohni bolte hain sir, opening. Kohni bolte hain sir, auspicious first customer or first. Kohni, not Kohni Kapoor sir. Anyway, sir, मैं एक और कमेंट करना चाहता हूँ हमारे वेंसडे सीएमबी के बारे में. It's just like hotel midway when we go and in middle of the week we have fun. So, my few questions are about ultrasound being used as repair for the valves. How good and where from it came?
Yes, I think recently there was a data of nearly 300 patients of severe aortic stenosis and ultrasound therapy in that, and that showed that delayed. So what happens that if the valve is very calcific, the ultrasound would is like a pulse therapy, like a lithotripsy, where the calcium union is broken and the valve opening becomes a little better, but it's nowhere cured. So what happens that if you give ultrasound therapy, it has delayed, so it has made severe aortic stenosis into moderate aortic stenosis, but it doesn't cure it. So it can delay the definitive treatment.
The corollary to that is in total occlusion. Earlier, rotor-letter was the only way. Now, IPL has come. So, has the rotor-letter been the back seat or obsolete now?
No, so it's not never going to be obsolete, because for IVL, you need to take the IVL balloon across the lesion. So suppose the lesion is so tight that wire has not crossed, so you need to do a rotablation to create a space to take the IVL balloon there. So it's not going to be obsolete.
You talk about absorbable stents again after a gap of many years. Many other places wherever, say even knee replacement and all, they have been newer devices, but they say use the generic, use made in India. Is there anything specific for absorbable stents also?
Yeah, so I think the only place where the absorbable stent is still available and approved by the government is the Indian absorbable stent. It is made by the Indian company Marine Life Sciences, and that is available right now. Not anywhere else in the world. So anywhere else it is available. It is the
My last question, sir, about syncardia, the artificial heart as a bridge therapy. Have you ever used, or are we in a process to use, or we are likely to use?
No, so we have used at least 10 odd cases, and it's something which is really helpful in these end-stage heart disease patients.
External counterpulsation. Are you using in your practice in selected cases, or it is obsolete?
No, so it's coming back in a big way. External counterpulsation has been, non-invasive therapy, and in non-revascularizable cases, it is definitely it has. So in fact, external counterpulsation has come as a preventive therapy for heart disease also.
सर हैप्पी न्यू ईयर. बड़ा अच्छा लगा सर. सर एक डर हर वक्त सताया जा रहा है. अभी हमारे डॉक्टर संजीव थे, इज अ रेडियोलॉजिस्ट, उनको एकदम से हार्ट अटैक आ गया और बड़ी मुश्किल से उनको बचाया. दुबला पतला सा बंदा और उसको भी हार्ट अटैक. आप सर हमको खाली इतना बताइएगा कि हम बहुत यहाँ पर हमारा जो लाइफ स्टाइल है बहुत गलत है, खूब खाते हैं तो एक्सरसाइज कुछ नहीं. इस एज में क्या हमको सबको आपके पास आना पड़ेगा और एंजियोग्राफी कराना पड़ेगा? क्या ये सही है कि नहीं सर? सच बताइए.
So I think I always say the heart attack is an accident, and if you are watchful, you can avoid the accident. Meaning thereby that if you are careful about your diet, and also if this thing is done once in a week, that is pardonable.